So maybe we can begin with Professor Arthur Sitt on his talk, which is extremely important about episcleral venous pressure and its management in practical life.
Okay, well, thank you, everyone. It's a real pleasure to be here. So I'm going to talk today about application of episcleral venous pressure management in practical life. These are my disclosures, and I have worked with a few pharmaceutical companies who have interest in EVP. So when we think about EVP, it's useful to first talk about the anatomy. So the conventional outflow pathway, as you all know, starts as aqueous humor passes the trabecular meshwork into Schlemm's canal, and from there it goes into the collector channels, and then into the aqueous veins, and then into the episcleral vessels. And the pressure in the episcleral vessels really forms a floor, which limits how low intraocular pressure can go. And that's shown as clearly to us by the modified Goldman equation, which relates intraocular pressure to the rate of aqueous humor formation, uveal scleral outflow rate, outflow facility, and episcleral venous pressure. And you can see that episcleral venous pressure stands alone there in that equation. So first, how do we measure EVP? So measurement of EVP is a little tricky, actually. So we have to have a device that places a clear silicone balloon on the eye. It ramps up the pressure and collapses an episcleral vein, and we video that as it's happening, and we also measure the pressure while it's happening. And then we take those images and we do some image processing, look at the brightness profile across the vein, and then we can look at the change in brightness as that vein collapses. And using this information, we can then go back and calculate the point at which the vein just starts to collapse. And that's actually what corresponds to episcleral venous pressure. So we can measure it. So we can then start to think about what are the things that regulate and change episcleral venous pressure. So one thing is body position. So this is a study that we did a few years ago. With a group of volunteers, young volunteers obviously, because they had to get into this rather uncomfortable position at the slit lamp. And we compared EVP in this position versus EVP sitting upright. And what we found is that when the subjects go into a semi-prone position, their IOP goes up from about a mean of 11.4 to a mean of 13.1. But then their EVP goes up as well from 6.4 to 7.8. And that change in ILP is about the same as the change in EVP. So based on this, we think that the positional change, at least in the steady state, the positional change in ILP is due to the positional change in EVP. Now, intraocular pressure and aqueous humor dynamics also undergoes a circadian variation, and most dramatically, aqueous humor formation drops by about 50% at nighttime. But EVP has a lot of variation, but on average, the mean EVP is no different from the mid-diurnal period to the mid-nocturnal period. Daytime about 7.44 mean and nocturnal 7.41. But if we look a little bit more carefully, instead of just those 2 time points, if you look at the diurnal period from 8 a.m. in the morning to 4 p.m. in the afternoon, we know that ILP has a diurnal pattern where ILP starts out higher early in the morning and decreases over the course of the day. It turns out that EVP also has a diurnal pattern where it starts out higher in the morning and decreases over the course of the day. And so from this, we surmise that change in IOP over the course of the day is largely, but not completely, explained by the change in EVP. So EVP clearly is influencing ILP through its circadian rhythm. So how does the EVP actually change? Well, there's a couple of ways. Well, one is you can dilate episcleral veins, and that definitely lowers EVPs to some degree. But it's a little bit complicated because there are also these arteriovenous anastomoses between the arterial episcleral vessels and the venous episcleral vessels. And you can imagine if you were to dilate these arteriovenous anastomoses, you end up arterializing the venous side. So dilation of those vessels actually raises EVP. And that was shown to us by Jeff Keel in rabbits, where he had nitric oxide donor, nitroprusside. So nitric oxide, of course, is a vasodilator. So if you give that to rabbits, it causes an increase in episcleral venous pressure, whereas if you have L-name, so that's a nitric oxide synthase inhibitor, so it increases the amount of, or decreases the amount of nitric oxide. And if you give that, then EVP actually decreases. So that's consistent with the idea if you dilate too much of the anteriovenous anastomoses, you're going to actually increase the pressure. So, in humans, though, there are other studies. So in rabbits, one of the things that, again, Jeff Keel showed is that proparacaine can decrease episcleral venous pressure. Pretty significant drop in rabbits if you use their system where you take down the conjunctiva, place proparacaine on the eye, and measure directly with an invasive procedure to cannulate the vessels. We tried to replicate this in humans, though, and we found that if we took a group of healthy volunteers, soft contact lens wearers, so that we could measure their EVP with and without anesthetic, and they're used to having things touching their eyes, we found that application of proparacaine did not change EVP. And so that was a little bit different than rabbits, but of course in humans we don't take down their conjunctiva before applying the topical anesthetic. Phenylephrine is a vasoconstrictor, of course, and what we did find, though, is that application of phenylephrine does decrease episcleral venous pressure in human subjects, and that's consistent with the idea that if you constrict the AVAs, then you're going to reduce the arterialization of the venous sides and reduce episcleral venous pressure. How about glaucoma medications? So in rabbits, it's been shown that brimonidine can decrease episcleral venous pressure. We haven't looked at this in humans yet, but we have looked at other medications. Notarsidol in particular is primarily a drug that works on the trabecular outflow system, so at the trabecular meshwork, improving outflow facility, but also reducing episcleral venous pressure by, again, dilating those episcleral vessels and reducing EVP by about 1 millimeter of mercury. And then there's other drugs. There's a new drug being developed called from QLaris Bio called AIOS2025. It's based on a ATP-sensitive potassium channel opener called levchromacalum. And what's really interesting about this drug is that it doesn't affect, it lowers RLP, but it doesn't affect outflow facility, uvoscleral flow rate, aqueous humor production, but it does lower episcleral venous pressure. And so it seems like this new drug in development may be the first drug that actually directly targets episcleral venous pressure. The trials in humans still need to be performed, though, and there's a version of this drug called QLS-111, or QLS-111, which is currently in clinical trials. So, knowing that we can that EVP is regulated and we can modify EVP, when is EVP reduction potentially most helpful? And I point to this article which was actually just published just a couple of weeks ago, actually, where we review a lot of this information. And there are definitely some patient groups where reduction of EVP may be most helpful. So normal tension glaucoma patients are one. ILP is already low. And so when ILP is already low, reduction of aqueous humor production or improvement of uvoscleral outflow facility actually has a limited effect because you can't go below EVP, which is typically about 6 to 8 millimeters of mercury. Whereas if you reduce EVP, that gives a 1-to-1 reduction in ILP. Angle surgery is a group where this may be particularly helpful as well. So angle surgery already optimizes outflow facility. That gives you a larger denominator in this equation, and so reduction of Q or U has limited effect. And again, EVP and LP vary in a 1:1 ratio, so this may be particularly effective in these groups as adjunctive therapy. Same with SLT, really the same arguments there. And then patients who have very low pressures, target pressures in the low teens or less. And typically these are patients who you've already tried aqueous humor suppression through medications, you've already tried to improve the uveal scleral flow, again through prostaglandin or maybe through surgery or SLT or MIGS. And so that leaves EVP as the untreated target here in the modified Goldman equation. And in these patients, EVP is going to be 50% or more of their actual ILP, so it's an obvious place to try to target. And then finally, elevated ILP. So if you have a patient like this who has a severely dilated episcleral vessels from a carotid cavernous fistula, you're going to want to treat the underlying mechanism first, obviously. But after that's been done and you want to try to reduce episcleral venous pressure, then that is a reasonable target. Once we have medications that will target EVP as its primary mechanism. So to summarize, EVP is important. It can be measured objectively. It varies with body position and diurnal rhythms. Its regulation seems to be through dilation as well as through their arteriovenous anastomoses. Medications can affect EVP, and we're getting more medications that can better affect EVP. And then reduction of EVP is going to be most likely useful in patients who have low ILP, and its use will either be a standalone therapy or as adjunctive therapy. So thank you very much, and look forward to seeing everyone in Hawaii.
Thank you. Any questions? Yes, please. Aparna, can you come? Your talk is.
Fascinating talk, great science. I have two questions. One is, does Rho kinase inhibitor have a different mechanism of action by which it is allowing the AV things to dilate but still lowering EVP?
Yeah, no, that's a great question because it's a vasodilator, and so the speculative answer, we don't have any definitive answer, is that different concentrations of drug may have different effects. So you may need a greater concentration to start dilating the AVAs as compared to the episcleral veins themselves.
I see. And thank you. And the second question is, when you measure EVP, which vein do you choose? Because there are,
Yep.
3 or 4 calibers. Which
Yep.
one do you choose?
Yeah, so we typically choose the ones that are easy to access. So that would mean superior or supratemporal. I mean, it's difficult to measure nasal just because the nose gets in the way. We can measure inferior, but it's a little bit less comfortable for the patient.
But do you go with the first vein that collapses, or do you go with the largest vein that collapses?
So we go with, so we typically target a vein that is nicely visible. And the balloon doesn't give uniform pressure, so we want to center over the vein. So if we have a peripheral vein off to the edge of the balloon that collapses sooner or later, it's probably not giving an accurate reading.
I see. Thank you.
Any other? Yeah, Mike.
Fantastic stuff. In real life, we get a lot of red eyes from eye drops, including chronic prostaglandin use, with the argument that there is a chronic dilatation of those anastomotic vessels. And those of us in clinical trials work out that sometimes you take people off prostaglandins, their pressure goes down. Do you think that's the mechanism? Is that what's happening?
Yeah, I mean, it's interesting. I mean, it's certainly possible that there's some segment of the population that is more sensitive to Rho kinase inhibitors, and they're actually getting dilation of the AVAs. I actually think it's more just a matter of those eyes are so red and irritated. I mean, I'm sure you've seen it, patients who have medication allergies. If you take them off of the offending agents, their pressures go down. I think it's probably more that effect, but it's certainly possible that there are some patients who are more susceptible to a lower concentration of drug, and they are getting elevation of EVP.
Is there a subset of patients that you would like to, test for their EVP, or do you do it in a routine practice?
Yeah, I wish I could do it routinely. It's not an an easy procedure to perform. So right now we're only doing it for research purposes.
Thank you.
I have a question, sir. It's a very interesting talk. So you mainly said that EVP loading may be effective in patients with normal tension glaucoma. Any conditions where you think where the EVP is elevated? For example, we are very interested in our patients with thyroid ophthalmopathy, which have long-standing ocular hypertension not resulting in glaucoma. So could there be role in such patients where EVP is high and we lower it?
Oh, no, absolutely. I mean, that's not a group that I've thought about, quite frankly, but I think it's certainly possible with the orbital congestion that you could have elevation of episcleral venous pressure just from putting pressure on the vessels there and causing a back pressure. So I think it'd be very interesting to measure those patients and see what the effect of EVP lowering treatment is.
Any scope of that balloon that you're using to be available commercially?